The Radioactive Iodine Uptake, or RAIU, study is the quantification of radioiodine accumulation within the thyroid gland. It determines the fraction of an administered dose that is retained in the thyroid at specific time intervals. This quantitative assessment evaluates the overall functional status and iodine kinetics of the gland, moving beyond simple structural visualization. These macroscopic results directly represent the operational efficiency of microscopic cellular transporters. The process begins with the oral intake of iodine 123 or iodine 131, which is typically administered as a sodium iodide capsule or liquid. Once in the proximal small intestine, the ingested iodine is reduced to iodide. This iodide is primarily absorbed in the duodenum and jejunum, reaching 90 to 95% bioavailability within the first hour. At the thyroid follicular cells transport of 2 sodium ions with 1 iodine ion inward. Powered by the sodium-potassium ATPase pump, this active trapping generates an internal iodide concentration 25 to 500 times higher than plasma. This primary active trapping engine establishes the baseline for how the gland will interact with any circulating radiotracer. At the apical membrane, pendrin translocates the trapped iodide into the colloid. During organification, thyroid peroxidase oxidizes the iodide, incorporating it into thyroglobulin. An RAIU test provides clinical data that directly reflects the efficiency of microscopic cellular transporters. The crucial distinction between NIS trapping and TPO organification dictates the overall clinical interpretation of the resulting data. When a patient presents with thyrotoxicosis, dangerously elevated circulating thyroid hormones, blood tests cannot identify the underlying cause. We have to look directly at the behavior of the gland itself. The RAIU differentiates the underlying causes of thyrotoxicosis. Hyperfunctioning conditions like Graves' disease, toxic adenoma, and toxic multinodular goiter present with increased uptake. A decreased uptake indicates glandular destruction, as seen in thyroiditis, or extrathyroidal factors like iodine overload and factitious thyrotoxicosis. Identifying the distinction between a hyperactive basolateral pump and acute tissue destruction determines the next steps in clinical management. RIAU measurements help estimate the required therapeutic activity of iodine 131 for Graves' disease, toxic goiters, or thyroid cancer treatment. Multiple timed measurements are required to calculate the residence time of the radiotracer within the gland. This residence time is a critical variable in individualized dosimetry formulas, such as the Quimby-Marinelli formula, which determines the exact therapeutic dose. In neonates, the RAIU is used alongside the Perchlorate discharge test for congenital diagnostics. This combination evaluates congenital hypothyroidism by identifying specific organification defects. Thyroid peroxidase deficiency is the most common cause of dyshormonogenesis leading to these defects. The workup also identifies pendrin syndrome, a major metabolic defect involving the pendrin transporter. True kinetic quantification requires a tracer that completes every stage of the biological process, from cellular entry to molecular incorporation. For a standard differential diagnosis, it's the underlying causes of thyrotoxicosis. Technetium-99m scintigraphy is frequently selected. This is particularly true for children and lactating patients, where the lower radiation dose and rapid imaging turnaround are beneficial. The standard normal range for technetium uptake is 0.5 to 4% at 20 to 30 minutes. In iodine-sufficient regions like Saudi Arabia, Nepal, Namibia, Brazil, and Australia, that normal range is lower, typically between 0.2 and 2.5%. Technetium-99m is trapped by the NIS, but cannot be organified, eventually washing completely out of the gland. Technetium cannot diagnose organification defects. Technetium-99m is only a surrogate parameter for cellular trapping. Iodine isotopes provide a true, stable metric of metabolic organification. If iodine 123 is used for an RAIU study, breastfeeding must be interrupted for 48 hours. For technetium-99m, the interruption period is 24 hours, as it has a lower breast milk excretion rate. Iodine 131 remains strictly contraindicated for the duration of lactation. These tracers require strict clinical safeguarding because the same kinetics that make them diagnostically effective also pose risks to developing physiological systems. Before moving forward with any RAIU study, there are safety gates to clear. Radioiodide administration is strictly contraindicated during pregnancy. Fetal thyroids begin concentrating iodine between 10 and 12 weeks of gestation, and iodine 131 leads to irreversible fetal hypothyroidism. Consequently, pregnancy tests are mandatory for women of childbearing age before the administration of any radioiodine. An RAIU measurement is a sensitive environmental metric. It responds to the patient's exact physiological state. Contextualize these kinetic variables requires a clinical history, starting with direct physical findings like a palpable goiter or even exophthalmos. We screen for hypermetabolic signs, palpitations, heat intolerance, active weight loss despite high appetite, and severe tremors. We screen for the hypometabolic inverse, fatigue, cold intolerance, weight gain, and slow heart rate. Among these symptoms, the most deceptive anomaly is subacute thyroiditis. If a patient reports a recent viral illness, followed by sharp neck pain, the thyroid tissue is likely inflamed. This damage spills pre-made hormones into the blood, causing lab tests to show severe hyperthyroidism, while the RAIU scan drops to nearly zero because the damaged gland has stopped trapping new iodine. Euthyroid sick syndrome presents a similar challenge, broadly reducing RAIU during severe systemic illness without reflecting a failure of the thyroid itself. Without a granular clinical history, clinicians risk misinterpreting acute tissue inflammation or a passing systemic illness as chronic metabolic failure. We also need to clear up a persistent clinical misconception regarding iodine allergies. While patients may report severe reactions to iodinated contrast dyes, diagnostic radioiodine uses subpharmacologic levels of iodine. At these microscopic amounts, allergic reactions do not occur. The patient must remain fasting, receiving nothing by mouth for at least 2 hours before and after administration to ensure predictable absorption. An empty stomach guarantees 90 to 95% bioavailability of the radioiodine within the first hour. Once absorbed, the measured radioactive uptake is determined by the patient's existing plasma iodine concentration, following an inverse mathematical relationship. If the patient's plasma pool is already flooded with stable iodine, the thyroid will ignore our radiotracer. This necessitates strict withdrawal timelines. Every drug that alters the iodine pool must be discontinued according to its half-life. Amiodarone sits at the very top. This antiarrhythmic medication is 37% iodine by weight. Because of this iodine load, the drug forces a holding period of 3 to 12 months or longer. Dropping to the 4 to 8 week window, we withdraw oil-based iodinated contrast agents and iodine solutions like Lugol's or SSKI. Synthetic hormones follow. Levothyroxine is held for 3 to 4 weeks, while liothyronine clears faster, requiring a 2-week hold. In the final days, we hold perchlorate for 1 week, and antithyroid drugs like methimazole or PTU for 3 to 7 days. Failing to respect this exact kinetic timeline guarantees a poisoned baseline pool and an invalid clinical study. For 1 to 2 weeks prior, patients are placed on a low iodine diet, keeping intake below 50 micrograms a day. This starves the thyroid, forcing it to trap the radioiodine dose aggressively. This chart maps exact suppression thresholds. A continuous daily intake of just 1 milligram for 2 weeks diminishes uptake. A single massive dose of 30 milligrams creates a total blockade, suppressing the gland for weeks. Those stray milligrams are found in specific dietary staples. Kelp, seaweed, cabbage, turnips, and heavily iodized salt will override the starvation state. Unchecked dietary habits completely hijack the entire uptake mechanism, rendering the diagnostic isotope effectively invisible to the scanner. Beyond direct iodine loading, we have to navigate complex chemical illusions. The Wolff-Chaikoff effect occurs when an elevated plasma iodide level transiently suppresses organification inside the thyroid. In chronic kidney disease, impaired filtration causes iodide to accumulate, forcing the radiotracer uptake artificially low, masking true function. Conversely, systemic hyperthyroidism accelerates cardiac output and renal perfusion. The kidneys rapidly clear stable iodine from the blood. The starving thyroid aggressively traps any available tracer, driving the measured uptake artificially high. Lithium inhibits the release of thyroid hormone, but it does not stop the gland from trapping new iodide. Iodide flows into the cell easily, but the exit is blocked, causing particles to pile up, resulting in a false reading of elevated thyroid tension. Because of this retention property, lithium is occasionally used therapeutically to prolong the half-life of radioiodine during hyperthyroid treatments. The psychiatric and cardiac outliers, specifically lithium and amiodarone, carry the potential to distort that delicate baseline. Because these medications stabilize volatile conditions, their discontinuation must be managed exclusively by the prescribing physician. The true trapping function of the thyroid is only revealed once renal clearance, diet, and clinical history are aligned. Unlike diagnostic imaging that maps anatomy, the RAIU test generates no images. It is an exclusively quantitative procedure that captures data using a highly restricted non-imaging scintillation counting device, known as a thyroid probe. Extracting accurate data from this probe requires a rigid protocol. The practitioner must select the exact radiopharmaceutical dose, enforce strict geometric alignment between the probe and the patient, and calibrate every reading against a standardized physical phantom to correct for the hardware's severe native inefficiencies. Radiopharmaceutical selection is a strictly calibrated mathematical process. The practitioner must balance the need for adequate counting statistics against firm radiation safety limits, matching the exact isotope and microcurie count to the patient's specific physiological state. This matrix outlines the strict clinical dosimetry protocols for the RAIU. The administered activity and the specific isotope selected, whether iodine 123 or iodine 131, are highly variable and dictated entirely by the clinical scenario. For a routine uptake measurement performed without an accompanying scan, the high sensitivity of the single detector allows practitioners to use extremely low baseline doses. Iodine 123 is the preferred radiopharmaceutical here. Standard adult doses range from 50 to 100 microcuries. If iodine 131 is used for a routine uptake, the dose is restricted between 4 and 10 microcuries. While some older guidelines recommend pushing that to 15 microcuries for better counting statistics, exceeding 15 microcuries should be strictly avoided to minimize unnecessary radiation exposure. The dosing parameters shift entirely when morphological information is required alongside functional data, such as when evaluating palpable thyroid nodules or locating a substernal goiter. This is the combined scan and uptake scenario. For a combined procedure, iodine 123 is administered at a much higher range of 200 to 400 microcuries. This is the preferred method, as its 159 keV energy is ideal for diagnostic imaging, and it lacks damaging beta emissions. Iodine 131 is never administered as a single large dose for a combined procedure. Instead, the practitioner performs the imaging scan using a completely different radiopharmaceutical, technetium-99m per technetate, and subsequently gives 5 to 10 microcuries of iodine 131 exclusively for the uptake measurement. Practitioners must note that attempting to calculate an uptake percentage directly from the technetium is highly unreliable. Technetium is trapped by the thyroid gland, but it is not organified. It provides a surrogate parameter, not a true metric of iodine metabolism. The highest dosing protocols are reserved for whole-body scintigraphy following a thyroidectomy for well-differentiated thyroid cancer. This 24-hour test evaluates surgical adequacy, locates distant iodine-avid metastases, and dictates the precise therapeutic dosage needed for future ablation. In the cancer scenario, iodine 123 doses scale up between 2 and 4 millicuries. The 2 millicurie baseline is utilized for patients in a hypothyroid state, while the higher 4 millicurie dose is required for patients stimulated with recombinant human TSH. If iodine 131 is used for cancer surveillance, the dose ranges from 1 to 4 millicuries. Patients prepared via thyroid hormone withdrawal receive 1 to 2 millicuries to prevent stunning, a phenomenon that reduces the uptake of subsequent therapeutic doses. Conversely, patients prepared with recombinant human TSH require 3 to 4 millicuries to overcome the competitive inhibition from the stable iodine present in their levothyroxine medication. For pediatric patients, the routine use of iodine 131 is strongly discouraged due to the high radiation dose delivered to the gland. The North American Consensus Guidelines standardized pediatric iodine 123 administration at 7.5 microcuries per kilogram of body weight, capped between a minimum of 27 and a maximum of 300 microcuries. Capturing the data from these specific doses requires specialized hardware. The non-imaging thyroid probe is engineered not for spatial resolution, but for isolated gamma counting. The core detection component is a thallium-activated sodium iodide crystal. This crystal is optically coupled directly to a photomultiplier tube, which converts the light flashes from gamma interactions into measurable electronic pulses. The standard probe utilizes a 2 by 2 inch crystal. Its specific thickness, ranging from 25 to 50 millimeters, guarantees a much higher probability of complete gamma ray absorption than the thinner crystals found in standard gamma cameras. Because the crystal must only measure radiation emitted directly from the thyroid, the probe is equipped with a lead flat field collimator. This structure ensures a uniform geometric response within a 10% margin of error at a specified distance. The collimator achieves this through precise physical dimensions: a 17-centimeter deep conical cavity with a front opening roughly 10.5 centimeters in diameter, which tapers down exactly to the 2-inch face of the crystal. To prevent stray scatter from outside the targeted thyroid region from reaching the crystal, the entire detector and photomultiplier assembly is encased in a layer of lead shielding, approximately 12.5 millimeters thick. The signal is processed through a high-voltage supply, an amplifier, a pulse height analyzer, and a scaler. Before any patient measurements occur, this electronic chain undergoes strict daily quality control, checking mechanical safety, background count rates, and a standardized energy calibration using a cesium-137 source. The hardware is intentionally restrictive. The heavy shielding and deep collimation ensure that the detector registers measurable activity exclusively from that isolated 10.5 centimeter frontal field. Even with an isolated field of view, the hardware has severe physical limitations based on the energy of the isotope. Detection efficiency represents the probability that a photon entering the crystal will produce a signal, while the lower energy technetium-99m has a detection efficiency of 84.3%. The higher energy iodine-131 drops to 47.4%, and cesium-137 registers at only 18.2%. This formula calculates geometric efficiency. This is the exact fraction of emitted radiation that actually reaches the face of the probe in the first place, regardless of the crystal's ability to detect it. Geometric efficiency is entirely governed by the outside diameter of the crystal and the distance of the source from the probe, represented by x. At the standard 25-centimeter clinical measuring distance, the geometric efficiency is roughly 0.256%. By multiplying the detection efficiency by the geometric efficiency, we find the overall counting efficiency. For an iodine-131 dose measured at 25 centimeters, the overall efficiency is an abysmal 0.1213%. The probe misses nearly 99.9% of the emitted gamma rays. Because absolute efficiency is practically non-existent, clinical accuracy requires abandoning absolute measurements entirely. The reliability of the RAIU value depends solely on a relative comparison between the patient's neck and a calibrated known standard. To establish this relative baseline, the protocol mandates the use of the standard neck phantom. This physical tool is a solid right circular cylinder machined from lucite. Lucite is specifically utilized because its radiation attenuation properties perfectly match human soft tissue, replicating the exact scattering conditions of a patient's neck. The standard phantom measures 12.5 to 15 centimeters in diameter, with some 10 centimeter variants available to match varying anatomy. It features a hollow cutout designed to hold a standard 30 milliliter capsule of iodine-131 or a barium-133 mock iodine calibration source. The cylinder is engineered for both horizontal and vertical orientation and incorporates etched scrib lines on the surface to guarantee precise spatial alignment with the probe. The lucite phantom acts as the critical diagnostic bridge. By perfectly simulating human tissue scatter, it translates the highly inefficient native detector physics into biologically accurate, standardized measurements. Electronic filtering strips away scatter radiation. A pulse height analyzer is strictly calibrated to the energy signature of the administered isotope. For iodine-131, we isolate a 364 kiloelectron volt photopeak within a narrow 30% window. If the practitioner is using iodine 123 instead, the MCA must be adjusted to isolate its lower energy 159 keV photopeak. The clinical counting protocol begins by orally administering the calculated dose to the patient with a small sip of water. The exact time of administration is recorded for decay correction. The patient must remain fasting, receiving nothing by mouth for at least 2 hours after administration to ensure predictable absorption. The baseline is established by placing the calibration standard into the lucite phantom. The room background radiation is tracked for 1 minute, and the phantom itself is counted for 1 minute at a standardized fixed distance of exactly 25 centimeters. Crucially, the patient must be instructed to void their bladder immediately prior to counting. A full bladder introduces extrathyroidal scatter radiation that falsely elevates background readings. The patient neck measurement mirrors this geometry. The probe is positioned precisely 25 centimeters from the anterior surface of the patient's neck, ensuring the entire thyroid gland rests within the isocentric field. The gland is then counted for exactly 1 minute. A patient thigh measurement is taken at that identical 25 centimeter distance. Counting the mid-thigh isolates extrathyroidal circulating blood pool activity, so it can be factored out, provided the bladder is kept completely out of the probe's field of view. This sequence of counting the neck and the thigh is standardly executed at 2 strict intervals, 2 hours and 24 hours post-administration. Practitioners must remain aware of a physiological variable known as the Graves' disease trap. Early measurements taken at the 2 to 6 hour mark is mandatory. Patients with Graves' disease exhibit highly accelerated iodine turnover. Their uptake percentage will often spike massively at 2 hours, but drop back into normal ranges by 24 hours. Missing that early spike leads the physician to severely underestimate the required therapeutic dose. From start to finish, the methodology is rigid. You are strictly controlling external physical and biological variables to extract a reliable, repeatable metric from an imperfect one. This formula represents the final mathematical synthesis used to generate the exact percentage of radioactive iodine uptake. The first critical step happens in the denominator. The net phantom counts acquired at baseline must be actively decay corrected so they perfectly align with the exact 2-hour or 24-hour timeframes when the patient measurements actually occurred. The numerator extracts the true isolated glandular activity. The patient's 1-minute thigh background count is subtracted from their 1-minute neck count, mathematically stripping away circulating blood pool radiation. By dividing this isolated glandular activity by the decay-corrected phantom baseline, the formula outputs the final percentage of RAIU. Today, the thyroid functions within a completely transformed nutritional environment, one that is defined entirely by the saturation of universal iodine supplementation. In the 1960s iodine deficiency era, 15 to 50% uptake was normal. Universal salt iodinization sharply dropped the gland's needs to trap iodine. 2012 Ames data confirms modern ranges plummeted to 1 to 7% at 2 hours and 7 to 18% at 24 hours. Alongside this functional drop in uptake, the physical size of the gland has adapted as well. The mean thyroid volume in healthy individuals has steadily decreased to roughly 4.9 to 10.4 milliliters. In a clinical setting, a patient may present with a suppressed TSH and a 24-hour uptake returning between 19 and 35%. A veteran clinician might look at that 19 to 35% and instinctively code it as normal, based on historical textbooks. Under modern parameters, however, that uptake is definitively elevated and necessitates treatment consideration. Accurate interpretation requires a strict diagnostic triad. You have to synthesize the raw quantitative uptake percentages with scintigraphic imaging patterns and the patient's biochemical status. Relying on outdated numerical thresholds risks entirely missing active hyperthyroidism. A modern diagnosis demands cross-referencing the exact uptake fraction against physical structural behavior. This diagnostic matrix maps how we isolate thyrotoxicosis causes. We begin on the left branch, examining mechanisms actively driving physiologically elevated uptake. Graves' disease is the primary driver. Current reference ranges sit at 16 to 48% at 2 hours, climbing to 48 to 75% at 24 hours. Looking at this scintigraphy scan, we see how those quantitative numbers physically manifest. Notice the uniform, intense radiopharmaceutical absorption saturating both large lobes of the gland. Now contrast that with this scan of a toxic multinodular goiter. Instead of diffuse saturation, we see multiple discrete, hyper-functioning hot nodules, while the surrounding background tissue is almost entirely suppressed. High uptake can also be transient. In Hashitoxicosis, the early inflammatory phase of Hashimoto's thyroiditis, patients experience an intense Graves-like spike in trapping, sometimes reaching up to 21% at 24 hours. When antithyroid drugs are abruptly stopped, blocked receptors suddenly reactivate, aggressively stripping iodine particles from the fluid stream. The gland can also be forced to upregulate its trapping by external pressures. This occurs during extreme environmental iodine deficiency, where an iodine-deficient thyroid upregulates its symporters to capture every available molecule, or from TSH-like stimulation caused by a hydatidiform mole. Then there is pharmacology. Type 1 amiodarone-induced thyrotoxicosis occurs specifically in patients who already have underlying nodular or Graves' disease. Because amiodarone is 37% iodine by weight, the drug acts as raw combustible fuel for that pre-existing diseased tissue, heavily driving hormone synthesis and spiking the uptake percentages. Whether propelled by autoantibodies, autonomous nodules, or pharmacological fuel, elevated uptake points to an overactive physiological engine that requires targeted clinical suppression. Moving to the right side of the diagnostic matrix, we find the inverse presentation: thyrotoxic patients exhibiting severely suppressed or entirely absent iodine uptake. A suppressed uptake points to the cellular trapping machinery being shut down. This scan illustrates what near-zero trapping looks like. Against the visible anatomical marker points, the gland itself fails to visualize entirely. A blank scan often points to the destructive thyroiditis spectrum, encompassing the subacute, silent, and postpartum phases. Here, the gland is not overactive, it is isically injured. Injured follicle cells physically fracture open, leaking preformed hormone out, while completely losing the ability to trap new iodine molecules. This precisely distinguishes amiodarone type 2 from type 1. Type 2 is a purely destructive thyroiditis, where the drug inflicts direct cellular toxicity, resulting in severely suppressed uptake. Uptake will also flatline due to interference. If a patient is taking excessive exogenous thyroid hormone, their endogenous TSH is suppressed, shutting down the gland's trapping mechanism. Massive systemic iodine overload, frequently from radiographic contrast, triggers the Wolff-Chaikoff Effect. This temporarily paralyzes the gland's organification process, driving tracer uptake towards zero. The most complex paradox is the Basedow phenomenon. A patient with underlying thyroid disease receives a massive iodine load, triggering extreme thyrotoxicosis. Yet because the plasma iodide pool is completely saturated, the radiotracer cannot penetrate the cells, resulting in a severely suppressed uptake scan. If neck uptake is suppressed despite high hormones, functional tissue may be located elsewhere, such as the pelvic region. A suppressed scan in a thyrotoxic patient rules out classical hyperthyroidism, forcing a search towards systemic inflammation, massive exogenous contamination, or hidden ectopic synthesis. Translating these findings into the final diagnostic report is a rigorous process. The final write-up serves as a rigid legal document that dictates definitive patient management. The document must log precise inputs, demographic identifiers, current TSH and free T4 levels, an explicit history of interfering medications, and the exact radiopharmaceutical dose and route of administration. It then delivers exact outputs. You must record the quantitative percentages at 2 and 24 hours, culminating in a definitive diagnosis that explicitly answers the referring physician's original question. Because this test involves radioactive isotopes, patients often anticipate strict isolation protocols. However, diagnostic iodine uptake utilizes trace activities, rendering high-dose therapeutic isolation completely unnecessary. Instructing these diagnostic patients to avoid close physical contact only causes undue anxiety. Careful, standard personal hygiene is entirely sufficient to ensure safety. Intake of fluids promotes rocket filtration through the kidneys, efficiently flushing these diagnostic radiotracers completely from the bladder reservoir. Facilities should provide patients with wallet-sized travel cards. Highly sensitive radiation detectors at international borders and airports will flag even these trace diagnostic isotopes. There is one critical, legally enforced exception to these relaxed rules: patients who are lactating or breastfeeding. For iodine 131, the Nuclear Regulatory Commission issues an absolute mandate. Breastfeeding must be terminated permanently for that infant, backed by strict verbal and written confirmation. By contrast, if iodine 123 is used, breastfeeding only needs to be withheld temporarily. It can be safely resumed after a strict 48-hour clearance window. This data table explains these legal mandates, dictated by underlying dosimetry physics. Iodine 131 has an 8-day half-life, delivering a massive 11 millisieverts per megabecquerel. Iodine 123 has a 13-hour half-life, delivering a fraction of that dose, at just 0.20 millisieverts. The radioactive iodine uptake test gives a strict baseline of thyroid kinetics, but some clinical scenarios require actively manipulating that baseline to achieve therapeutic results. Take patients presenting with non-toxic nodular goiters. Here, the target tissue needs a push to absorb enough iodine for treatment. We do this using recombinant human TSH, or rhTSH. By injecting the patient with rhTSH, clinicians can artificially double the 24-hour radioactive iodine uptake levels. This forced doubling serves a specific structural purpose. It drives enough radioactive iodine into the tissue to achieve effective volume reduction of the nodules during therapy. This protocol becomes especially critical in geographic regions where the population has a high intake of dietary iodine, which normally dilutes the uptake of the radioactive tracer. By administering synthetic stimulation, clinicians bypass the environmental iodine saturation, ensuring the treatment reaches the necessary concentration to shrink the nodular disease. When tracking post-thyroidectomy thyroid cancer patients, the methodology shifts. The standard localized neck probe is abandoned. In these specific oncology cases, the uptake percentage is derived entirely from whole body scans instead of a single point measurement. Using specialized camera software, draw precise regions of interest, or ROIs, directly over the patient's neck anatomy on the digital scan. These isolated ROIs are then mapped against a calibrated standard to guarantee absolute quantitative accuracy. This comparison allows the clinical team to precisely pinpoint the location and volume of any residual thyroid tissue or metastatic disease left behind after surgery. Spatial tracking turns a simple uptake percentage into a high-precision oncological map, dictating the next phase of post-surgical monitoring. The Perchlorate Discharge Test, or PDT, is the primary diagnostic tool for evaluating iodide organification defects, such as the TPO enzyme deficiency seen in Pendred syndrome. The mechanism relies on the perchlorate anion. Because its ionic size and charge perfectly mimic an iodide ion, perchlorate acts as a highly effective competitive inhibitor. It targets the sodium-iodine Symporter on the thyroid follicular cell membrane. Perchlorate physically obstructs the channel, blocking iodide transport without actually being internalized itself. Under healthy physiological conditions, iodide enters the cell and is rapidly oxidized by the thyroid peroxidase enzyme within 2 to 3 hours. Once oxidized, that iodine is firmly incorporated, or organified, into thyroglobulin. At this point, it is locked in. It cannot wash out of the gland. But an organification defect introduces a mechanical failure. The gland lacks functioning peroxidase, meaning the iodine remains free and unbound within the follicular cell. When perchlorate is administered, it displaces this unbound radioiodine, causing it to rapidly leak or discharge back out into the patient's bloodstream. By utilizing competitive inhibition to flush out any non-incorporated iodine, the PDT effectively isolates and tests the specific organification phase of thyroid synthesis. The procedure begins with the oral administration of a radioactive tracer, typically 50 to 100 microcuries of iodine 123 or 5 to 10 microcuries of iodine 131. An identical amount of activity is simultaneously placed in a standard neck phantom to serve as a precise baseline reference. Exactly 2 hours post-administration, the clinician uses a thyroid probe to measure the patient's baseline uptake percentage. Immediately following this baseline reading, the patient receives an oral dose of potassium perchlorate with water, ideally given after a light meal to mitigate nausea. For adults, the standard protocol calls for a single dose of 400 milligrams. Flat doses present toxicity risks in small children, so pediatric protocols shift to body surface area measurements, typically 300 milligrams per square meter. For newborns undergoing evaluation for congenital hypothyroidism, the dose is to between 90 and 100 milligrams. Following the dose, the clinician waits exactly 2 more hours before taking a follow-up uptake measurement. A negative test, meaning normal organification, is confirmed if the uptake levels drop by less than 10% from the established baseline. However, a reduction greater than 10% indicates a positive result for an iodide organification defect. The defect is classified as partial if the discharge falls between 10 and 90%. A discharge greater than 90% indicates a total organification failure. The total percentage of radioiodine lost directly quantifies the severity of the underlying peroxidase deficiency or thyroglobulin defect. Historically, clinicians utilized potassium perchlorate as an active treatment for hyperthyroidism, managing conditions like Graves' disease and amiodarone-induced thyroid dysfunction. The therapy was ultimately discontinued due to severe adverse effects. Chronic administration was linked to life-threatening conditions, including aplastic anemia and nephrotic syndrome. Furthermore, applying perchlorate blockades in patients with insufficient dietary iodine can actively precipitate goiter and clinical hypothyroidism. These combined safety concerns prompted the FDA to restrict the chemical, even revoking its approval for use in sealing gaskets for food containers. Despite this toxicological history, the single controlled diagnostic dose utilized in the perchlorate discharge test is safe. The severe risks were strictly associated with the chronic, high-dose therapeutic regimens of the past. The Triiodothyronine, or T3, suppression test determines if thyroid tissue or specific nodules are functioning autonomously, ignoring the normal hypothalamic pituitary thyroid feedback axis. The mechanism relies on forcing negative feedback. By administering exogenous T3, the elevated hormone levels in the blood naturally signal the pituitary gland to stop secreting TSH. In normal physiology, this sudden lack of TSH stimulation causes a marked decrease in the gland's ability to take up radioiodine. The procedure requires an 8-day protocol. The patient takes oral T3 following a standard regimen of 75 micrograms daily or 25 micrograms 4 times daily. A healthy response is confirmed if the follow-up uptake falls below 50% of the initial baseline and drops to less than 10% overall. An autonomous response looks completely different. The tissue doesn't rely on TSH to function, so it continues absorbing radioiodine without dropping, bypassing the feedback loop. By observing the reaction to the hormonal blockade, clinicians could definitively separate normal TSH-dependent nodules from toxic autonomous ones. Today, the T3 suppression test is no longer routinely performed in clinical practice. The entire 8-day procedure was rendered obsolete by the development of highly sensitive serum TSH assays. The logic of the modern blood test is straightforward. If a patient is unmedicated, but their serum TSH is suppressed near zero, it indicates the pituitary is already reacting to excessive autonomous hormone production. A single, direct biochemical measurement of TSH provides the exact same diagnostic data as the week-long radiometric provocation. Nuclear pharmacy starts with high-concentration, volatile stock solutions of I-131 sodium iodide. A standard thyroid uptake study requires an administered activity of only 4 to 10 microcuries. This comparison illustrates the physical constraints of the stock solution. Drawing exactly 10 microcuries directly from the stock would require a volume of just 0.01 milliliters, a droplet too small to measure accurately in a clinical syringe. To resolve this, we employ a 2-step serial dilution. This protocol uses a mathematical workflow to expand that unmeasurable volume into a standard clinical range. Because I-131 is volatile and emits radioactive gas, all preparation occurs inside a certified radioisotope fume hood. We use closed vials to contain the solution, equalized air pressure to prevent gas escape, and lead shielding to protect. This dilution sequence serves as a safety-engineered bridge, moving the material from hazardous stock concentrations to precise diagnostic doses. In step 1, we withdraw exactly 1 millicurie from the main stock, injecting it into vial A, a sterile container with 9 milliliters of saline. Since 1 millicurie equals 1,000 microcuries, the 10 milliliter volume of vial A now contains 100 microcuries per milliliter. In step 2, we transfer exactly 1 milliliter from vial A into a second 10 milliliter vial labeled vial B, which also contains 9 milliliters of saline. This creates the patient working solution. The concentration is now exactly 10 microcuries per milliliter. This table illustrates how this concentration simplifies dosing. A 4 microcurie dose is now a manageable 0.4 milliliters, while a 10 microcurie dose requires 1.0 milliliter. Using 0.4 milliliters instead of a microscopic droplet significantly reduces measurement error. This larger volume also allows the dose calibrator to provide the stable, verified readings required for quality control. This process fulfills ALARA safety standards. A potential spill of this final diluted solution is 10,000 times less radioactive than a spill of the original stock solution. In Graves' disease, TSH receptor antibodies stimulate the entire gland. This results in a diffuse, uniform distribution of the tracer, often reaching an elevated uptake of 48 to 75% at 24 hours. Toxic multinodular goiters and adenomas present a different pattern, involving autonomous nodules that overproduce hormone independently of TSH. Scans show high localized uptake within these nodules. The excess hormone suppresses the body's TSH production, making surrounding healthy thyroid tissue appear dark. We use the RAIU scan to categorize the clinical state of thyrotoxicosis. It differentiates cases of active hormone overproduction from cases caused by cellular leakage. Hashitoxicosis, the early phase of Hashimoto's thyroiditis, involves follicular destruction. It can temporarily show an increased uptake that mimics Graves' disease. We also monitor the Basedow phenomenon, where thyrotoxicosis is triggered by a large iodine load, such as medical contrast dye, in a patient with underlying thyroid autonomy. This creates a diagnostic paradox. Despite the hyperthyroid symptoms, the RAIU scan is suppressed because the patient's iodine pool is already saturated, preventing the tracer from entering the cells. In hyperfunctioning states, the RAIU signature corresponds directly to the spatial distribution and severity of cellular autonomy. Destructive conditions produce an opposing signature. In subacute thyroiditis, inflammation destroys the follicles and causes stored hormone to leak into the blood. While blood hormone levels are high, the RAIU is severely suppressed, often below 1%. The damaged cells are physically unable to trap the new iodine tracer. We see similar suppression in silent and postpartum thyroiditis, as well as the chronic phase of Hashimoto's, all due to cellular injury or autoimmune destruction. In standard hypothyroiditis, reduced renal clearance expands the extracellular iodine pool. This dilutes the radioactive tracer, leading to a low % uptake. For neonates with congenital hypothyroiditis, the RAIU scan determines if the thyroid gland is absent, ectopic, or present but malfunctioning. Inherited metabolic defects, known as dyshormonogenesis, are evaluated by pairing the RAIU scan with a perchlorate discharge test. This diagram shows an organification defect. Iodine enters the cell but fails to bind to thyroglobulin, often due to a TPO deficiency. The graph shows an initial spike as iodine is trapped, followed by rapid washout. The cell cannot retain the tracer, confirming the defect. This washout pattern is diagnostic for Pendred syndrome, a genetic disorder involving an organification defect, sensory neural hearing loss, and goiter. These suppressed or washing out signatures indicate that thyrotoxicosis is caused by structural damage or metabolic failure, rather than active hormone synthesis. In oncology, well-differentiated thyroid cancers retain a limited ability to trap iodine. Following a thyroidectomy, we use RAIU scans to identify residual tissue or iodine-avid metastases. This contrasts with benign goiters in iodine-deficient areas, which aggressively trap the tracer, resulting in elevated RAIU levels. RAIU also identifies functional thyroid tissue in mediastinal masses that extend into the chest. In struma ovari, ectopic thyroid tissue in an ovarian teratoma causes thyrotoxicosis. The scan shows high concentration in the pelvis, while the neck remains dark due to TSH suppression. Gestational tumors, such as hydatiform moles, produce high levels of HCG, which acts as a TSH agonist and can increase RAIU. Systemic factors also alter the scan. Chronic kidney disease reduces iodide excretion, raising plasma levels and triggering the Wolff-Chaikoff effect, which decreases uptake. Dietary iodine deficiency has the opposite effect, upregulating the sodium iodide Symporter and leading to significantly higher uptake. The RAIU scan tracks a systemic metabolic pathway that reflects ectopic tissue, renal function, and dietary saturation. We have tracked two primary pathways: functional autonomy, which traps the tracer, and destructive or systemic suppression, which leaves the gland dark. Patients with identical thyrotoxic symptoms require this physiological map to differentiate the underlying cause of their condition